Right now, as you watch this video, there are approximately 100 million adults in the United States living with diabetes or prediabetes. Of those, roughly 23 million have been diagnosed with type 2 diabetes and are not aware of it. Not because they have not been to a doctor, not because they have not had blood drawn, but because the standard fasting glucose test that most people receive at their annual physical catches diabetes only after years of metabolic damage have already occurred, and because the 5 signs that the body has been sending long before that blood test turns abnormal are almost never explained to patients in a way they can recognize and act on. I am going to explain those 5 signs to you today, not in vague terms, in the specific biological language of what is actually happening in your tissue and why it produces the signal you can see or feel on your body right now. By the end of this video, you will know more about how to recognize early diabetes than the majority of people who have already been to their doctor this year. I am Dr. David Miller. I have been practicing medicine for 15 years, and I built this channel on one principle. The information that could allow you to catch a life-altering diagnosis years before it becomes serious exists in the research literature and in clinical practice. What does not exist is a reliable mechanism for getting that information to the people who need it inside the standard clinic appointment. That is what I do here. Subscribe to Dr. Miller right now and hit that like button. We are building a community of people who understand their own metabolic biology well enough to recognize a warning before it becomes a crisis. Every subscriber makes this channel more visible to the next person who needs it. Before I describe the 5 signs, I want to explain something about diabetes that most people fundamentally misunderstand, because the misunderstanding is exactly why so many people are surprised when they receive the diagnosis after years of having had no idea. Diabetes is not a disease that begins the day your fasting glucose crosses the diagnostic threshold of 126 milligrams per deciliter. That threshold is the point at which the medical system formally recognizes the disease. The biological process that produces it begins years, sometimes a decade or more, earlier. It begins with insulin resistance. Insulin resistance is the state in which the cells of the body, particularly the muscle cells and liver cells that are the primary consumers of glucose, have stopped responding efficiently to insulin's signal to absorb glucose from the blood. When insulin resistance develops, the pancreas compensates by producing more insulin. More insulin is required to move the same amount of glucose into the cells. For years, sometimes for a decade, this compensation is successful. The pancreas produces enough extra insulin to keep blood glucose within normal range. Fasting glucose tests come back normal. The person is told everything is fine. But during all those years of successful compensation, something else is happening that the standard glucose test is not measuring. The elevated insulin itself is driving metabolic damage throughout the body. And the 5 signs I am about to describe are the direct consequences of that elevated insulin and early metabolic dysregulation, appearing on the body years before the glucose test becomes abnormal. The first sign is skin tags in specific locations. Skin tags are small, soft growths of skin that hang from the surface on a thin stalk. They are extremely common, and most people who have them have been told they are entirely harmless cosmetic findings. In most locations and in small numbers, that is true. But there is a specific pattern of skin tag development that is a direct marker of elevated insulin and insulin resistance, and it is one of the most consistently overlooked early signs of developing diabetes that I encounter in clinical practice. The connection is direct. Elevated insulin stimulates a class of growth factors called insulin-like growth factors, which bind to receptors on skin cells and promote their proliferation. When insulin is chronically elevated, as it is throughout the years of insulin resistance that precede type 2 diabetes, this proliferative signal is continuously active on susceptible skin cells. The result is an accelerated growth of skin tags in the areas where skin friction and moisture create the conditions those cells grow most readily. These areas are specific and consistent: the neck, particularly the back and sides of the neck, the armpits, the groin and inner thighs, the area under the breasts, The eyelids in some individuals. The pattern matters as much as the presence. A single skin tag anywhere is not a diabetes signal. Multiple skin tags appearing in multiple friction zones, particularly if they have appeared or multiplied noticeably in recent years, is a metabolic signal that correlates strongly with elevated insulin and insulin resistance. Studies have found that people with multiple skin tags have significantly higher rates of insulin resistance and type 2 diabetes than matched controls without them. This finding is in the dermatology literature, and it is almost never communicated to patients by the physician who has just told them their skin tags are nothing to worry about. The second sign is a dark velvety discoloration of the skin in specific areas of the body called Acanthosis nigricans. This is a finding that produces one of the most common questions I receive from patients who have noticed it and looked it up online, because the search results are alarming and the reality is nuanced. Acanthosis nigricans appears as patches of skin that are darker than the surrounding area and have a texture that is thicker, softer, and slightly velvety or rough rather than smooth. The color ranges from light brown to very dark brown or grayish, and the texture makes it look as though the skin is dirty, which is why many people scrub at it without result. It appears most commonly in the same friction and moisture zones as skin tags: the back of the neck, the armpits, the groin, the elbows and knees in some cases. The mechanism is the same insulin-like growth factor pathway. Chronically elevated insulin drives the proliferation of skin cells called keratinocytes and melanocytes in these areas, producing the thickening and darkening that characterizes the condition. The degree of acanthosis correlates with the degree of insulin resistance. In children and adolescents, its presence is one of the strongest visible predictors of progression to type 2 diabetes. In adults over 50, where it is more common and more frequently dismissed as hyperpigmentation or age-related skin change, it is equally significant and equally underinvestigated. If you have patches of skin in the zones I described that are darker and slightly different in texture from the surrounding skin and that have not been evaluated in the context of your metabolic health, they deserve that evaluation. Subscribe to Dr. Miller and hit the like button. The connection between Acanthosis nigricans and insulin resistance is taught in every medical school and appears in every endocrinology textbook. The problem is not that the knowledge does not exist. The problem is that a dermatologist seeing Acanthosis nigricans often treats the skin without ordering a fasting insulin level, and a general physician seeing it often mentions it as a cosmetic finding without explaining its metabolic significance. This channel exists to close that gap. Hit subscribe. Every subscriber means the next person with this question gets the full picture. The third sign is the specific pattern of fatigue that follows carbohydrate-containing meals. This is the one that most people experience and almost none connect to their metabolic health, because post-meal tiredness has been normalized to the point where most people consider it simply a biological consequence of eating. It is not. It is a symptom, and the specific form it takes in people with developing insulin resistance is distinct enough to be recognized if you know what you are looking for. When a person with normal insulin sensitivity eats a meal containing carbohydrates, the glucose from that meal enters the bloodstream, insulin is released in a measured amount, glucose is efficiently absorbed by the cells, blood glucose returns to baseline within 90 minutes to 2 hours, and the person feels energized by the meal. When a person with insulin resistance eats the same meal, the glucose enters the bloodstream as before, but the cells do not respond efficiently to the insulin signal. The pancreas detects the persistently elevated glucose and releases more insulin, then more. The eventual insulin surge is large enough to finally drive the glucose into the cells, but it often overshoots, driving blood glucose below the pre-meal baseline. This post-meal hypoglycemic dip, reactive hypoglycemia, triggers a stress hormone response including adrenaline and cortisol as the body attempts to bring glucose back up. The subjective experience of this sequence is a specific pattern, a brief sense of fullness or even mild energy after eating, followed within 60 to 90 minutes by a heavy, almost irresistible fatigue. sometimes accompanied by difficulty concentrating, mild headache, irritability, or a strong craving for something sweet to bring the energy back up. If you eat a moderate carbohydrate meal, not an extreme amount, a normal lunch with bread or rice or pasta, and you find yourself needing to sit down or even lie down within an hour, if the tiredness after eating is significantly greater than the tiredness before eating and consistently follows carbohydrate intake rather than all meals equally, that specific pattern is a metabolic signal worth investigating. It is not normal digestion. It is reactive hypoglycemia driven by the insulin overshoot of insulin resistance. The fourth sign involves the eyes, and specifically a change in vision that people over 50 frequently attribute entirely to aging. Fluctuating blurry vision that comes and goes, that is worse at certain times of day or after certain meals, and that is not fully explained by a stable prescription from an eye examination, can be one of the earliest ocular manifestations of elevated blood glucose. The mechanism is direct and physical. The lens of the eye maintains its shape through a careful balance of fluid and protein concentration. When blood glucose rises, glucose enters the lens cells and is converted to a compound called sorbitol by an enzyme called aldose reductase. Sorbitol does not exit the lens cell efficiently and accumulates there, drawing water into the cell by osmosis. The lens swells slightly, its curvature changes, its refractive power changes, vision blurs. When blood glucose subsequently falls, the sorbitol is slowly cleared, the water follows, the lens returns toward its normal shape, and vision improves. This cycle, glucose rises, lens swells, vision blurs, glucose falls, lens recovers, vision clears, can happen multiple times in a single day in a person whose blood glucose is fluctuating significantly, and produces exactly the pattern of inconsistent, fluctuating blurry vision that the person attributes to their aging eyes and their optician attributes to a need for a stronger prescription. The diagnostic clue is the inconsistency. Aging-related vision changes are stable. They do not come and go based on what you ate 2 hours ago. If your vision is measurably better in the morning before eating and worse in the afternoon after a carbohydrate-containing lunch, if your reading clarity fluctuates in ways that do not correlate with fatigue or lighting but do correlate loosely with your meals, that pattern belongs in a conversation with your physician about your fasting glucose and your post-meal glucose, not solely in a conversation with your optician about your prescription. The fifth sign is the pattern of healing, specifically the rate at which small wounds, cuts, scratches, and abrasions on the skin resolve. In a person with normal glucose metabolism, a small cut heals cleanly within 5 to 7 days. The inflammatory phase is brief. The proliferative phase in which new tissue is produced is efficient, and the remodeling phase that restores skin integrity completes within 2 weeks for small injuries. In a person with elevated blood glucose, even in the range below the formal diabetes threshold, each of these phases is impaired. Elevated glucose directly impairs the function of the white blood cells responsible for clearing bacteria and debris from a wound. It impairs the function of the fibroblasts responsible for producing the new collagen that fills the wound. It impairs the growth of the new blood vessels that supply the healing tissue. And it creates a chemical environment in the wound fluid that is more hospitable to bacteria and less hospitable to the enzymes driving repair. The result is wounds that take longer than they should, that sometimes become slightly red or swollen at the edges when a wound of that size in a healthy person would not, that leave slightly larger scars than expected, or that occasionally become mildly infected from minor injuries that would not have become infected in younger years. Most people over 60 attribute this to aging, and aging does impair wound healing to some degree, but the specific pattern of significantly prolonged healing times that seem disproportionately long for the size of the injury, repeated minor infections from small cuts, persistent redness around healing wounds that would normally have been unremarkable, is a metabolic signal on top of the aging baseline. If a cut on your hand regularly takes 2 to 3 weeks to fully close and leaves a more prominent mark than injuries of that size left 10 years ago, and particularly if this change has been progressive over the last several years, it belongs in the conversation about your metabolic health. Now, I want to give you the practical framework because recognizing these signs without knowing what to do with them is incomplete. If you recognize one or more of these signs in your own body, the investigation begins with a specific blood test that is not the standard fasting glucose. It is the fasting insulin level. This test measures how much insulin your pancreas is producing to maintain your current blood glucose level. A fasting glucose in the normal range with a fasting insulin that is elevated means your pancreas is working significantly harder than normal to maintain that normal glucose, which is the definition of insulin resistance that the glucose test alone does not detect. This test is not exotic. It is available at any standard laboratory. It must be specifically requested because it is not part of the standard metabolic panel. The optimal fasting insulin level is below 5 microunits per milliliter. Levels between 5 and 10 indicate developing insulin resistance. Levels above 10 in a fasting state indicate established insulin resistance regardless of what the fasting glucose shows. The second investigation is a 2-hour post-meal glucose measurement, also called a postprandial glucose test or an oral glucose tolerance test. This measures blood glucose 2 hours after consuming a standardized glucose load and reveals the blood glucose dysregulation that occurs after meals, but not in the fasting state, which is the phase of metabolic dysfunction that produces the post-meal fatigue, the lens swelling, and the reactive hypoglycemia I described. A 2-hour glucose below 140 is normal. Between 140 and 199 is impaired glucose tolerance, the clinical term for prediabetes. Above 200 is diabetes by the World Health Organization criteria, even with a normal fasting glucose. The dietary intervention with the strongest evidence for reversing insulin resistance at the early stage, before the fasting glucose has crossed the diagnostic threshold, is the reduction of refined carbohydrates and added sugars combined with an increase in dietary fiber. Every gram of fiber consumed with a carbohydrate slows the absorption of that carbohydrate from the gut, reduces the magnitude of the post-meal glucose spike, and reduces the insulin demand that spike creates. This is not a low-carbohydrate diet. It is a slower carbohydrate approach, replacing refined bread with whole grain, adding vegetables to every meal, eating protein and fat before carbohydrates in a meal rather than after, which has been shown to reduce post-meal glucose peaks by 30 to 40% in people with insulin resistance. These changes, applied consistently over months, reduce the insulin load on the pancreas, allow insulin sensitivity to partially recover, and reverse the skin, vision, healing, and energy consequences I have described. How old are you? Write it in the comments right now. I want to see the age range of this audience because it determines what I focus on next. If most of you are in your 60s, I want to address the specific test sequence for distinguishing insulin resistance from early type 2 diabetes, because the distinction matters for intervention and most people have never been told there is a meaningful difference. If many of you are in your 70s, I want to discuss what the research shows about insulin resistance reversal at that stage, because the conventional assumption that it becomes progressively harder to reverse with age is not as absolute as patients are often led to believe. I am Dr. David Miller, and I have spent 15 years watching people receive a type 2 diabetes diagnosis that arrived as a complete surprise because nobody had explained to them that their skin, their energy, their vision, their healing, and their metabolism had been broadcasting the approaching diagnosis for years. The 5 signs I described today are in the dermatology literature, the endocrinology literature, the ophthalmology literature, and the wound care literature. They are known. They are documented. They simply do not make it from the specialist journal to the person sitting in the clinic who needs to know them. Subscribe to Dr. Miller. Hit the like button. Share this with someone who has skin tags, darkening skin in their neck or armpits, afternoon crashes after lunch, blurry vision that comes and goes, or wounds that heal more slowly than they used to. Their body has been sending signals. Now they have a way to read them. The healthcare system profits from managing diabetes after it is diagnosed. I profit from you catching the warning years before that point. Subscribe if that difference matters to you. This content is educational in nature and does not constitute personalized medical advice. If you recognize any of the signs described in this video, please speak with your physician about appropriate metabolic testing, including fasting insulin and post-meal glucose assessment. Early identification and intervention produce significantly better outcomes than management after formal diagnosis.